Hello, good morning, everyone. My name is Sonya. Thank you, Dr. Chow, for that kind introduction. So, as you mentioned, I'm going to talk about, in the cardiology world, the second most important organ, the lung. It's not quite like the Rolls Royce of echo, which is cardiac echo, but hopefully I can convince you a little bit today that it does have some clinical utility in your everyday practice. So I have no conflicts of interest. My personal disclosure is that I am by no means a echo expert. I'm in the very early stages of learning, having started my critical care fellowship this July. And I think it's really important to mention my teacher. So Dr. Alberto Goffi, he's a staff intensivist at St. Michael's Hospital, and he's taught us, he is really the brain, the heart behind the critical care ultrasound program here, and he's taught us a lot. So a lot of the concepts I'll be talking about and some of the articles I'll be sharing were things that he taught us. Just to orient you, so first we're going to talk about the utility of lung ultrasound for some common lung pathologies. We'll discuss some image acquisition, and I promise it's a lot easier than cardiac echo. And we'll talk about some of the advantages and disadvantages, and then we'll discuss how ultrasound, specifically lung ultrasound, is being implemented into our guidelines. So anytime you are trying to introduce a technology into practice, typically you want to compare it to the standard of care. And so on looking at multiple studies, lung ultrasound has really shown that it can be more specific than chest radiograph for common conditions such as pneumonia, ARDS, pleural effusions. And so that's what I'm going to try and prove to you today. In some domains, specifically in interstitial diseases, it can really rival chest CT. And as we know, it's portable, it's rapid, it's dynamic, meaning that things that we do to patients, either changing their volume status or ventilation, can all have changes to that we can immediately see. The use of lung ultrasound with procedures is long known, and so that's not new, and I'm going to try and convince you today that it's quite easy to learn. So let me show you the proof. So starting out by discussing 3 different articles. And this first study here was a study by a group from Minneapolis, which was published in 2020. The patient population was medical, surgical, and neurological patients in ICUs at a 62-bed ICU urban teaching hospital who all had acute respiratory failure from multiple etiologies. This was a prospective cohort study which evaluated the agreement of a 9-point pulmonary ultrasound. You can see that on the left-hand side here. Each lung zone was the size of a hospital badge, and they compared it to chest radiograph for the localization of pathology to the specific anatomic lobe. The gold standard for this test was the CT scan. So they looked at 67 patients who met inclusion criteria, and these patients were all intubated for acute respiratory failure. Within the first 24 hours of their intubation, they underwent lung ultrasound, chest x-ray, and the gold standard here, CT chest. All lung ultrasound examinations were performed and read by physicians who had 3+ years of experience, and there was a 1-hour session prior to classifying to just refresh the zones that they were looking at. So on lung ultrasound, the zones were identified as either A, normal, so the presence of A lines, which we'll discuss a little bit later in the presentation, or abnormal. And this was further subclassified into severity. Based on the appearance, the examiner did make assumptions about etiology. So they listed whether they thought this was interstitial, ground glass effusion, or consolidation, or atelectasis. The chest x-ray and the CTs were read by an expert radiologist who was blinded. And what they found is that overall agreement of lung ultrasound with CT was 87% compared to 62% with chest x-ray. And the greatest difference was in interstitial findings. So lung ultrasound is really good at picking up these interstitial lung patterns in comparison to chest x-ray. Also, the clinicians had to make a guess as to what pathology the patient had, and the diagnosis in 62 out of 67 patients was accurate on lung ultrasound. Lung ultrasound had also significantly better lobe-specific agreement, which is not surprising because you can move the probe around and see many more sections than you can see on an x-ray. So let's take it to a different study in Spain. So we're moving from Minneapolis to Spain here. This was a single observational descriptive study. It was retrospectively analyzed, and it was carried out in patients who presented to primary care center in Spain during the COVID pandemic between March 2020 and September 2020. The inclusion criteria was quite broad. It ended up being patients over 18. They had to have had lung ultrasound. They had to have suspected COVID prior to their PCR result, defined by the presence of at least one symptom, so fever, cough, dyspnea, or oxygen saturation, and there was no exclusion criteria. Lung ultrasound was conducted by scanning 4 zones on each lung, a total of 8 different points. Each patient received a chest x-ray as well, and this was all prior to their PCR results coming back. Each chest x-ray and lung ultrasound was interpreted by the same physician. The chest x-rays were considered normal or abnormal, and then the lung ultrasound was categorized based on B lines, which we'll talk about, or which signify pathology. And they were given the option to say whether it was a normal pattern, a diffuse, or a local pattern. 212 patients underwent lung ultrasound, and a total of 187 of those also underwent chest x-ray. PCR was performed for all patients. And what they found was that the sensitivity for diagnosing COVID-19 with lung ultrasound was 83% versus chest x-ray was 54%. When they looked at patients with severe COVID, so severe interstitial lung disease, lung ultrasound achieved 100% sensitivity. So again, we're seeing that same pattern where lung ultrasound is outperforming chest x-ray in sensitivity. The specificity is not statistically different. And so what this study brings up is that lung ultrasound was potentially able to find these lung injury, like perhaps find acute lung injury more quickly than chest x-ray. The third study I want to raise is that there's been multiple studies done in high-income countries which have shown the benefit of ultrasound in comparison to chest x-ray for the diagnosis of pneumonia. And I think we sometimes forget that pneumonia is one of the leading causes of death in the world, disproportionately affecting low-income countries. And so this was a study that was done in Nepal. It was a prospective study which included patients presenting into the ED with clinical suspicion of a pneumonia in the hospital in Kathmandu Valley between November 2016 and March 2017. The resident and the staff were provided training in lung ultrasound. They received 1-hour lecture on lung ultrasound, followed by a week of performing lung ultrasound in the department. And so every patient that came in and had suspicion for pneumonia had lung ultrasound, a PHS X-ray, and a CT, which was again used as the gold standard. Lung ultrasound diagnosis was defined as the presence of unilateral B lines or subpleural lung consolidation. Chest X-ray and CT were read by a board-certified radiologist who was blinded. And so overall, the study had 62 patients. 71 had radiographic evidence of pneumonia on CT scan. Lung ultrasound was positive in 40 out of 44 of those patients, demonstrating a sensitivity of 91%. Chest X-ray was positive in 32 out of 44 patients, yielding a sensitivity of 73%. Again, specificity was not statistically significant. And when they actually did a subgroup analysis, there was not a lot of ultrasound interpretation variability. And so why I bring this up is because in research, it's really important for studies to be reproducible in order to allow us to have confidence in a technology. And so these are 3 different studies. One is in the States, one is in Spain, one is in Nepal, with all different sets of patients and different providers with varying experiences. And yet we're seeing a lot of the similar results across the board. One thing I put in here, which is a little bit fun, is a study that looked at the ability of people who weren't physicians to perform and interpret lung ultrasound. And so this was a systemic review which looked at the ability of nurses, medical students, and paramedics to perform lung ultrasound and specifically detect B lines and pleural effusions in patients who had heart failure or had symptoms in keeping with heart failure. And so the secondary goal of this was also to determine the exact level of training to be proficient in lung ultrasound. 14 studies in total were included. 5 studies looked at nurses, which had didactic training ranging from 0 to 12 hours and 58 to 62 practice examinations. They were pretty good, and their sensitivity to detect pathology was between 79 and 98%. The nurses that worked in cardiac centers tended to be better, and the amount of time that they spent ultrasounding was between 0 to 4 minutes. Medical students were not as good. They had about 1 to 8 hours of didactic training, an average of 1.25 hours of hands-on training, and their sensitivity ranged between 50 to 100%. The interesting thing is that they were really quick learners. So the difference between what they knew beforehand and what they knew after the session was nearly doubled. So they were very teachable. And the paramedics, there was only one study. They had 30 minutes of didactic training and 1.5 hours of hands-on training. And the endpoint for this study was predefined as greater than 80%, and unfortunately, they did not mean that. They did not meet that. And so what this shows you is that lung ultrasound is a learning curve, but it doesn't take a whole lot of hours to get there. Definitely less than cardiac echo. So let's talk about image acquisition, and I won't spend too much time on this because there's tens of different protocols for this, ranging from 2-zone lung ultrasound to 12-lung ultrasound. And so the important thing here is that there is 2 planes. There's a longitudinal plane and a transverse plane. Typically for structures that are closer, like the pleura, you're going to want to use your linear probe. And then for your deeper structures, like your pleural effusions and looking at your lower lung tissue, you may want to consider using your curvilinear probe. And this will also depend on the type of patient and the size of your patient that you have in front of you. Here, I've just included a more comprehensive protocol, which is the 12-lung protocol. Each lung is divided into 6 different segments to make 12. But you may say, I don't have time to scan every patient, in 12 zones when they come to my clinic. And so this is what I put in because I know that the group here is mainly cardiology. And so this study looked at 2 versus 8 zone lung ultrasound in heart failure patients, knowing that most scanning protocols in the literature are 8 or more lung zones. And so this particular study looked at the anterior left and right superior lung zones versus 8 zones. And what they showed is that the study showed that excellent agreement between average B-line severity, whether you use 2 or 8, and there was no statistical difference. Now, the one thing to consider in the study is they were looking at mainly edema, and so that's more of a diffuse process. And so this brings up the question of, do you need to be scanning every patient in 12 zones, or for some conditions, can we look at 2? Okay, so let's get to some practice, okay? So the first picture here I want to show you is what we call A-lines. And just to orient you, the top of the screen is skin. Right below it is subcutaneous tissue. That white pearly line is the pleural line. And the 2 dark spots above the pleural line are ribs. So you're looking between 2 ribs. And it's really important in lung ultrasound to know that what we're seeing is actually reverberation artifact. So those equidistant lines below the pleura, which are called A-lines, are just artifact of the pleura. And what they signify is that whatever is below that pleural line is actually homogeneous. And so whether that's normal lung tissue or that's air, you can't tell. All you can tell is that the underneath the pleural line, when you see these A-lines, there is homogeneous structure. Okay. So if there's one thing to take away from this talk, I think this is probably the most important. And so what we see here is lung sliding. So again, so you have your tissue at the top, subcutaneous tissue, your 2 ribs, and then you have that white pearly line that's moving back and forth. And so in a normal lung, so you have two pleura, a parietal and a visceral pleura, and they slide amongst each other like I don't know. Sometimes people describe ants on a and it's walking down, but they slide against each other and you can't actually see the separation, but what you can see is sliding. And what this tells you is that there's no air there. And so this is a very quick way to be able to rule out something like pneumothorax. And it's really important to note that when you put your probe on your lung here, you can only determine whether there's air in this specific zone. So there may be air or pneumothorax in another zone, but you can be pretty confident if you see this that there's no pneumothorax. And so we like to be able to validate ourselves with the tools we have. And so if you were to put your cursor over that pleural line and press M mode on your ultrasound, what you would see is this seashore sign. And so the top is subcutaneous tissue, which obviously doesn't or shouldn't move. Then you have your pleura, and underneath that, you have your sandy shore pattern, which is lung motion sliding. Another finding we're going to talk about is lung pulse. And so lung pulse is synchronized movement of the lung, and this pulse is reverberations from the heart. And so depending on where you are scanning, this may be bigger or smaller. And here in this picture, you can see the patient's breathing, but in between those breaths, you can see pulsations. And so if you were to have air here in this location where your probe is, you would not be able to see a lung pulse because obviously your reverberation would not transmit through air. And so this is another way to tell if you have a pneumothorax. So the absence of a lung pulse and the absence of lung sliding is equivalent to a pneumothorax. Now, there is a specific subset of patients that may not have lung sliding. So if you have really a consolidated lung, you may lose your lung sliding. If your patient holds their breath, you may not have lung sliding. If your patient's not ventilating, so for example, a VV ECMO patient that's being ventilated at a very low rate may not have lung sliding. Or if you have a transplant patient who has a little bit different anatomy, you may not see this lung sliding, but you should see lung pulse. So if you see lung pulse, you also don't have a pneumothorax. Okay, so let's go through some cases to be able to talk about some pathology. So you're the trauma bay leader and you have a 20-year-old female who unfortunately gets into a motor vehicle collision. And she comes into the trauma bay. She's previously healthy. It looks like she's got multiple injuries. So she arrives in a C collar to protect her C spine. And while you're preparing all your things, you see her vitals. So she has a GCS of 14. Her blood pressure is acceptable. Her heart rate's on the upper limit of normal. Her rest rate's on the upper limit of normal. And what's not acceptable here is her saturation, which is at 85% on room air. And so very quickly, you put her on some oxygen and you increase her to 95%. And at the same time, like a coordinated movement in the trauma bay, somebody comes over and takes a supine snapshot. And they look at you and they show you this. To me, this looks like a fairly normal chest x-ray. I don't see anything glaringly obvious. And so at the same time, your colleague is doing a FAST, which is part of the trauma workup, and then they hand you the ultrasound and you say, let me take a quick look at the lung. And this is what you see. So you've put your probe between you're using your linear probe here or your curvilinear, and you've placed it between the second and fourth intercostal. And I'll just play the video one more time. So you don't see any lung sliding and you don't see a lung pulse here. And just to confirm, you do the M mode and you see what we call as the barcode sign. And so there's no movement in that specific area. You then move your probe down a little bit just to convince yourself because you're a really good clinician and you want to be sure. And what you see is this. Okay, one more time. So this is what's called the lung point. And the lung point is when you can see the transition between normal lung sliding and the absence of lung sliding. And this is the transition point between the collapsed lung and the normal lung. And so why is this important in this patient population? Well, let's say her oxygen saturation starts to drop even further. Going through your ABC algorithm, you're likely going to put in a chest tube right now before you intubate a patient with a pneumothorax. The last thing you want to be doing is adding positive pressure to a pneumothorax. You're going to make it worse. So it does actually have the ability to change what you do acutely in this setting. You go on to CT scan this patient, and they end up having a large pneumothorax that was missed on a supine chest x-ray. And that's an important consideration in this population because oftentimes you can't sit these patients up. So this was a study that I wanted to include, and it was a prospective study performed. It was a single-blinded study carried out on 212 adult patients who had thoracoabdominal trauma. And they underwent an ultrasound that looked for pneumothorax as well as a supine chest x-ray. And only those that in which CT was able to rule out pneumothorax or rule in pneumothorax or a chest tube by the presence of air coming out, only those patients were actually included in the study. And that ended up being 118 out of the 212. And what they found was that there were 48 true positives on CT or chest tube. And they found that among these, ultrasound was able to correctly detect pneumothorax in 43 patients, while supine chest x-ray was able to identify 33 cases. And I think this is an important consideration because that's a big difference here. We talked about the fact that supine chest x-ray does underperform when air is involved because obviously you can't sit the patient up. But I think it's a really valuable finding, and trauma is one of the areas where ultrasound has been readily used. Okay, case 2, I think we've all seen this type of patient. So you're working in the emerge, an 80-year-old man arrives with shortness of breath. You say, great. They have a lot of information on Connecting Ontario, and then you open it up and it's a scroll. And as you're looking at Connecting Ontario, you're in a more rural setting, which my emerge docs will like to remind me is that even in places in Ontario that you would not expect, there's not CT overnight, and oftentimes you have to call in the x-ray tech to do your images. So the tech is waving goodbye to you as you walk in. They're leaving for the night and you're alone. These are the vitals on the left-hand side, and it's now up to you as to what you're going to do. You take a short clinical history, and then you reach out for your trusty ultrasound, and you start scanning the patient. And what you see is this. It's like a strobe light, similar to what you may have seen in a nightclub. And so these are called B-lines. So what are B-lines? B-lines are increased lung density. They can be really anything: atelectasis, consolidation, water, blood, proteins, lipids. And they're very sensitive, but they're not specific. And what's considered pathologic is greater than 3 or equal to 3 B-lines within an intercostal space. And they can correlate with severity, and we'll talk more about the future of that in terms of predicting what type of pattern they are. And they are dynamic in the sense that there have been studies that show that if you remove fluid off of a patient, you will immediately see that on ultrasound. But my point here is that although ultrasound is helpful, you're still going to have to make clinical decisions because ultrasound is not going to be the end all and be all of telling you what this patient has. It can only help you and help cue you as to what the patient might have. And so in this specific case, you slide down and you take a look at the space between their diaphragm and their lung. And what we see here is something called hepatization. And this is indicative of consolidation. And so we previously talked about that a lot of lung ultrasound is actually artifact. Well, here you start to see the lung is so consolidated that you actually end up seeing lung architecture. And so just to orient you, here's your diaphragm, here's your pleura, and then you see your lung here. And what this is here, it's not showing up on this computer as well as it is on my laptop here, but this is the shred sign. And so you're actually seeing the lung tip, which you should never see in a normal ultrasound. You're also seeing air bronchograms, which are these white dots, and they do tend to move with respiration. And then, of course, the black is fluid. The diaphragm is here. And so when you see this, you can be pretty sure that this patient, at least in some component, has a pneumonia, which may cue you to start some antibiotics. The one other thing I wanted to talk about is that lung ultrasound. So here is great at looking at empyemas, abscesses, and even rival CT in these domains. And so when you're looking at a patient, scan multiple areas, and you may find something that helps you build your case. Okay. The one other thing I wanted to talk to you is about timing. And so this was a study that Dr. Goffey actually brought to our attention, and I thought it was really interesting. It was a study that was performed in Italy, and they took pigs, I believe it was 10 unlucky pigs they used, and they injected them with oleic acid, which we know causes acute lung injury, and it's meant to mimic ARDS. And so they used ultrasound to look at 12 predefined scanning sites, which you can see up here on the left. And they used ultrasound to evaluate extravascular lung water. And what they called these, what would I call equivalent in humans, B-lines, is they call them lung comets. And they were reflective of pulmonary edema. At the same time, they looked at the P to F ratio, which is your arterial blood oxygenation. So, and the static respiratory compliance as well. And so what they did is they sedated these pigs, they paralyzed them, and they intubated them. All of these pigs had a Swan-Ganz catheter, and they had an arterial catheter in their carotid to be able to sample. And what they did is they measured all of these three parameters at 15 minutes, 30 minutes, 60 minutes, and 90 minutes after the initial oleic acid injection or insult. And so what they found is that after the study was done, all the pigs, unfortunately, were euthanized, and their tissue was sent to the pathology lab to look at. And that's what you see here in this left-hand corner. All the pigs had acute lung injury. And so we knew that the oleic acid worked, the treatment worked. And the number of ultrasound lung comets increased over time. And it was actually consistently present earlier than any change in the P to F ratio. And so specifically, these lung comets were statistically significant at 15 minutes. Static compliance was also statistically significant at 15 minutes and was reduced, which is what we would expect in ARDS. The PF ratio did not drop to a statistically significant point until 90 minutes. And so what this study raises is we can conclude that lung ultrasound can be used as an effective tool to detect lung injury earlier than clinical signs like a drop in oxygenation. And I bring this back to clinical practice. So Dr. Goffey, who was on service with the fellows, he told us the story about a patient on CCRT. And so he was called for a patient who had increasing oxygen requirements. And when he went to go see the patient, they were on, I believe it was moderate settings. And when you're working in the ICU, you have time constraints and you have bed allocation constraints. And so if you can keep a patient on the floor and treat them, that's excellent. So one thing that he did is he actually took an ultrasound and he looked at the lungs and he saw that there was a lot of B-lines. And so he ended up bringing this patient perhaps maybe a bit sooner than he would. And what happened is that the patient actually clinically deteriorated, however, in the ICU with the personnel and equipment necessary. And so we should explore this area more in being able to buy us some time, because time is very valuable in medicine. This last case, I'm not going to belabor too much because I think it's a little bit boring, to be honest with you. This is an 85-year-old man who comes in with metastatic lung cancer. He's on some oxygen and he wants to go home. And I think we all know the utility of ultrasound when it comes to procedures. So you do a chest x-ray and you see that there's a costophrenic blunting on both sides. So likely he has pleural effusions, and that points you to do an ultrasound. So we know that chest x-rays often under-detect pleural effusions and under-detect the size of pleural effusions. So this is another useful function for lung ultrasound. And so you put your curvilinear probe on the patient and you see that they've got a massive pleural effusion. And you end up doing a thoracentesis and hopefully sending the patient home. What I wanted to point out is two different things on this slide. So the first one is the spine sign. And so below the diaphragm in a normal patient, you should not be able to see the spine because your waves do not transmit through air. So when you see the spine below the diaphragm here, what that tells you is that there's either pleural fluid or consolidation that's allowing those waves to transmit through. And the second sign I wanted to talk to you about is the sinusoid sign. So you have your lung here, obviously your pleura here, and your pleural fluid in between. And so if you were to put your MO through this, what you would see is the sinusoid sign. And that is when the patient breathes, there's a change with respiration between the parietal and the visceral pleura. So I think I've kind of beat to death the advantages of ultrasound. The only other thing I would like to add is that it is no radiation, and that's important when it comes to our CCU populations or ICU populations who often get scanned, sometimes multiple times a day for several days. It does add up. Also, the utility of lung ultrasound is quite integrated in the pediatric population for this specific reason. The disadvantages, I think, are lower. It is user dependent, and it does take some time to learn how to use lung ultrasound and interpret it. But looking at studies, people are pretty good, and the variability between providers significantly decreases with training. B-lines are not specific. That's probably the biggest caveat, is that you have to interpret everything with caution. Now, there is some studies that are coming out, but nothing to my knowledge that is solidified. But people have looked at B-lines and the pattern of B-lines to say, well, this is ground glass, this is this, but that's probably going to be looked at a little bit more. And let's talk about the future and how it's being implemented into our current guidelines. So unfortunately, I didn't have a cardiac study or a cardiac guideline for lung ultrasound, so I have to stick with good old-fashioned ARDS. So acute respiratory distress syndrome was first described in 1967, and the physician looked at a set of 12 patients, and it was characterized by inflammatory edema, severe hypoxia, stiff lungs, and endothelial and epithelial injury, mostly through post-mortem studies at that time. So following that, experts met in Berlin in 1994, and the American-European consensus definition was defined. And it had 4 major criteria, which included timing. So it had to be 1 week, within 1 week of known clinical insult, hypoxemia defined by a PF ratio less than 300. The origin of edema had to exclude cardiac edema, which can be a little bit challenging to determine. And the patient had to have bilateral opacities, either defined by chest radiograph or CT. So we went on with this definition for multiple years, and then a group in Rwanda came out with the Kigali modification of the Berlin criteria, because according to this, none of their patients would have ARDS. And so they had to modify it to work for them and be able to treat their patients. And so what they had done is instead of the PF ratio, they used the SpO2 to FiO2 ratio. They didn't have access to blood gases, so that's why they used that. They didn't have access to ventilators like we do here, or the amount of ventilators, and so there was no PEEP requirement, and they ended up using a lot of high flow. And they didn't have access to CT scanners or chest X-ray, and so they used ultrasound often to look at these bilateral opacities. And so the world started to notice, and a more inclusive definition of ARDS came out. And so a new report in the American Journal of Respiratory and Critical Care Medicine was just released this September 2023 to include some of those considerations. And for the purposes of our talk, the big change that's important here is that ultrasound is now an acceptable way to be able to diagnose ARDS. One caveat that you might say is that because B-lines are not so specific, you may be picking up some patients who potentially who have cardiac edema, essentially. And so those are the newest guidelines up there. And they included this here to show what different ARDS patients look like. So the top one up here would have always been considered ARDS by the Berlin criteria, but the 2 below it would not have. And so our guidelines are changing to be inclusive of of both technology and how medicine is practiced in different areas of the world. I find that very exciting. And that's my presentation. So thanks so much for listening. Please feel free to add something or ask a question. Thanks so much.
Well, thank you.